So I think for a patient and for the doctor choosing a treatment, targeted therapy or a checkpoint blockade, we have several factors to consider. So one, targeted therapy is an oral treatment which needs to be continued on a daily basis. For checkpoint blockade, usually we have infusions on a 2 or 3 week schedule. The patient needs to come in, get an infusion for a short period of time. So how is that compatible with your daily life schedule, with working, vacation, and so on? We have now tumor control with these innovative treatments in melanoma for, on median, a year, so several months. So patients have to come in. Good prognosis patient with normal LDH and limited tumor burden. We have patients on treatment now, for example, with targeted therapies, we know that for 2 or 3 years. I think for oral drug, that's easier than for infusions to keep on going on a regular basis. Obviously, there are several other factors which influence the choice of targeted therapy or a checkpoint blockade. So is the patient willing to accept a certain toxicity? Compliance is an issue, for both kinds of drugs. For somebody who is taking an oral medication, he needs to accept that he takes his drugs on a daily basis. Compliance is also an issue for checkpoint blockade, because you need to report potential side effects, subtle changes in your well-being to the doctor, and see whether there's any hidden autoimmunity. Comorbidities will drive a decision to one or the other direction. For example, we know that targeted therapies have frequent influence on cardiac features, which potentially preclude a treatment with a BRAF or MEK inhibitor, what would allow treatment with checkpoint blockade. On the other hand, autoimmune diseases which are pre-existing could prevent a treatment with a checkpoint inhibitor and drive a patient to a targeted therapy. So it's a whole basket of different factors for a patient and for a doctor, which needs to be balanced in order to find the right selection for the patient. Right now, there is no evidence which is educating a patient or doctor what is better to start BRAF MEK and then, if in case of failure, follow with checkpoint blockade, or the other way around. Clinical studies are trying to address that, but it will take years before we have results at that point.